So like we explained in the last few slides, a child coming in with shock can have either of these three or maybe two or more of these three parameters involved. It can be a problem with the preload, it can be a problem with the contractility, or a problem with the afterload. And reiterating what preload and afterload are, preload is the wall stress at the end of diastole. So the amount of filling in of the chambers determines the contractility as per the Frank-Starling law. Contractility, all of us know. Afterload is the wall stress at the end of systole. So like this picture clearly depicts, so what goes out of the heart. So the tighter the afterload, the more the strain on the heart to pump. More lax the afterload, the more problem with the heart, because we have to keep filling it in to kind of pumping out an effective volume outside. There are, like I told you, three major types of shock: hypovolemic, distributive, and cardiogenic. Septic shock will fall into the distributive category. So hypovolemic, we know the volume is low, so preload is low, contractility may be normal, or as a compensation, it may be increased for a slight amount of time, and the afterload may be normal, or usually as a compensation will be increased to maintain the blood pressure. Like you see in a dengue shock, or in any kind of a hypovolemic shock, like a diarrhea child with shock, the initial heart rate will be high because the stroke volume is compensating. The contractility is more, and so the heart rate is high. The afterload may be more, and so the blood pressure may be normal for the first few hours, and later on the blood pressure kind of drops. In a dengue child, we have a narrow pulse pressure just before the BP drops, and narrow pulse pressure is because the afterload is high. Distributive and septic shock, in both of it, the preload may be decreased. The contractility may be normal or decreased depending on whether the sepsis has affected the myocardium or not. The afterload may usually be low. The SCR is low, and that is why in these two types of shock, we have this warm shock where the pulse volume is bounding, the pulse pressure is wide. So usually the afterload is low, or the systemic vascular resistance is low, and after a certain amount of time, it may kind of increase. Cardiogenic shock, usually the preload is normal, sometimes increased, contractility obviously is decreased, and the afterload is increased. So these are and if we know the type of shock that we are dealing with when we first receive the child, take that first 15 minutes, even half an hour max, to kind of, come to a conclusion on, okay, fine, this child is in hypotensive shock. It is possibly a distributive kind of shock where I know that preload will be low, SCR is probably low, and so the child will need fluids, and the etiology may be sepsis, so I know I have to give an antibiotic. I know if the pulse pressure is wide, I may have to start norepinephrine. So that, if it is running in your mind as you're seeing and treating the child, then your treatment as far as starting fluids, starting pressors or inotropes, giving the first shot of antibiotic, doing a blood gas, everything will automatically flow. And this is called critical thinking, or thinking on your feet in the emergency room or in the ICU. So like a guide to preload administration. So this preload administration is a very challenging, and I would say a very dynamic topic, because every couple of years or so, the pediatric critical care group and the surviving sepsis guidelines keeps changing their guide on fluid administration. But irrespective, once we know or we have diagnosed that the child has a hypovolemic shock, we need to give a volume bolus. So previously we used to give 20 per kg. The reason to give 20 ml per kg is because when 20% of the blood volume is lost as in, I'm not saying as in trauma, kind of a loss of blood, but be it redistribution, be it loose stools, vomiting, third spacing as in burns, third spacing as in dengue. So when the 20% of that volume is lost, that is when the blood pressure drops. And so that is kind of interpreted as a 20 ml per kg, and that is why the first bolus in hypotensive shock is always 20 ml per kg as a preload challenge. But when we have pure hypovolemia, like in, for example, I have a child with diarrhea, 20 episodes per day, and child is coming with severe dehydration, hypotension, here absolutely I will be giving a 20 ml per kg. But all other kinds of hypovolemic shock, be it dengue, be it septicemia, be it anaphylaxis, be it neurogenic. The first volume, what the surviving sepsis guidelines and the pediatric critical care group is now seeing is that use aliquots, which we have always been doing here, because we don't know where, we are basically customizing to the child. If we are going to be bedside and assessing this child, I would probably give a 10 ml per kg of normal saline, as a pull push, or when I put it on the pump, I set it as a maximum rate of 999. So it will go in, say, max 10 minutes. So as I give that volume of 10 per kg, and then I'll take a minute or less than a minute to reassess the pulse volume, look at the blood pressure, feel the perfusion, look at the CFT and the consciousness, and then decide on the next aliquot. So this is called titrated boluses. You're titrating to effect. But that's okay, even if you choose to give a 20 ml per kg in a child whom you've diagnosed to have either distributive or hypovolemic shock, then between a 10 to 20 ml per kg is good enough.